and she's going to tell us how to go about with it. There is also tomorrow in the afternoon, there is also a Polish wound management meeting where the D-Food session is also there. Okay, welcome Professor Beata from Poland.
Your invitation for this extremely important conference. And during this session, I would like to inform you, to share with you our new initiative of D-Food International, which will be a new declaration based on our Polish declaration, which was settled down 2 months ago. And we would like to show you the assumption of this declaration, share with you, and try to implement all over the world. First, I would like to show you some epidemiological data from all over the world and from Poland, which are showing you how important is to implement the assumptions of this declaration. I cannot follow on. One moment, maybe there is something. Yes. As you know, 100 years ago, it was shown by the very elegant information from Dr. Jocelyn in New England Journal of Medicine. It was 1934 that they were informing us, alarming that there is a food catastrophe. We are now 100 years after. And what is a global burden of diabetes all over the world? WHO and other institutions are alarming us that the incidence of diabetes type 2 is increasing. And if you are looking into the age of people who are the largest population, those are people between 40 and 60. And all of you dealing with patients with diabetic foot know that most of those having diabetic foot are in the range between 40 and 60. The alarming problem and the tip of the iceberg is the problem of children, and the incidence of children with type 2 is also increasing all over the world. And the International Working Group of Diabetic Foot is informing us that we are expecting in the near future the new patients with diabetic foot among children and adolescents. I will share with you some data from Poland. Officially, we have 7% of adult population with diabetes mellitus, and of those, 10 to 20% will develop diabetic foot. So it is around 300,000 of them. But the tip of the iceberg is that up to 40% of adult population could develop diabetic foot. Why? Because 40%, up to 40% of those will have diabetes or pre-diabetic status. From if we count about 10 to 20% of them, approximately 1 million of inhabitants could develop diabetic foot in my country. The worst situation is with wounds because you know that up to 70% of them will not heal within 20 weeks. And 20% of those who are infected will develop into a severe infection, and many of them will be unfortunately amputated. In the region where I do live, this is a central part of Europe. Every day, one major amputation is performed, and my region is a region of 5 million inhabitants. We were analyzing the data from different regions, and we found that in some regions, the rate of amputation is increasing and some is decreasing. And we wanted to analyze the reason of this situation. The other problem was the problem that up to 20% of people being amputated are informed they have diabetes in the moment of amputation. I took the picture you could see. I took it in 2014, being on a course on Charcot foot in Germany. This picture was taken during, as you could see, during the World Cup. It was the game between Brazil and Germany. when you could find in the end of the group of people the person who's on a wheelchair with diabetic foot. This is the problem with the social exclusion of those people. We are not telling about enough. And the Swedish data showed as well that those who were after a major amputation, most of them are not employed. 85% of them seek for help. 3/4 of them live in isolation. 1/4 of them do not have proper rehabilitation, and 10% of them remain in bed. The problem is that the situation after amputation is very bad because the 5th year mortality after major amputation is higher than most malignant cancers, what was shown by Professor Armstrong. Those are pictures taken in my clinic of those who were at risk of death because of necrosis, because of sepsis, and because of the consequences of having diabetic foot, among them cardiovascular events, just like myocardial infarction. We were analyzing the financial costs of diabetic foot, and we found that diabetes and its complications covers more than 10% of national health budget in Poland, and half of them are spent for diabetic complications. So what can we do? What are the possible ways we can do to stop this situation? We need time. Time is knowledge and experience. And we need money. Money means infrastructure and good stuff. One of our professors, who is a vascular surgeon, counted that 16 amputation, this is the money we have to spend for amputation, the same sum of money as for 120 ulcers which were healed, or 834 people in whom prevention was applied. So the question is, and Dr. Abbas, in his first presentation, showed who is really interested about politicians with our problem. As you see, nobody is. We are looking into the absolutely capital data results, which were shown us by Dr. Abbas, which he showed from the discoveries, from the experiences in Tanzania. It is absolutely wonderful that within 8 or 10 years, the amputation rate dropped down by 10%. And everybody is looking whether in his own country the similar program could be implemented. I'm showing you the picture we took during our annual conference, which was held 2 months ago in a small city named Kazimierz in Poland. And the name Kazimierz is from the king of Poland, who first, when he became a king, the houses were built by wood. When he was dying, mostly all of them were built by stones. So he was a builder, and we would like to build the new world when the patients with diabetic foot will have help from different directions. And we signed, being there during this conference, we signed the declaration, and the signatories of this declaration declare their willingness to take comprehensive measures to reduce the incidence of complications caused among them by diabetic foot, including mortality and other permanent sequelae, just like limb amputations. And all of you being here during this conference remember Saint Vincent declaration, which declared more or less the same, but we forgot about this declaration. And I think all of us being here, we have to remember it once more. And thanks to this new declaration, we would like to rebuild the same story and start, thanks to DFood International, thanks to implement the new ideas of this declaration. And first, we would like to look into the particular situation in particular country. We have to use the SWOT analysis, looking into the strengths, weakness, opportunities, and threats of the particular situation. What could be the strength? Housing base. We need clinics. We have to education. We have to consult. We need consultations. We have the possibility to create a food clinic. We need multidisciplinary teams, and we need good team cooperation. What about the weaknesses? There is in many countries limited availability of services depending on the country. For example, in my country, when the financing system is financing more of the procedures, patients are waiting too long for appointments, especially for revascularization. In many countries, there is lack of orthopedic facilities in the hospitals, lack of financing for full therapy from funds, medical funds, and insufficient knowledge among mainly surgeons, but not only. So it causes unnecessary and premature amputations. Now about chances. There is raising awareness of healthcare providers, raising patients' awareness, and promoting treatment and diagnostic standards among doctors. So they are creating a network of diabetic food clinics operating based on accepted standards. Now, threats. Further limitation of services, small number of clinics dealing with diabetic food, failure to comply with standards in the treatment of diabetic food centers by centers, and further failures in promoting diabetic food treatment methods and clinics among primary care physicians. So there are at least three main directions into which we have to go. First, healthcare authorities. We have to provide medical care at many levels, and we have to promote coordinator care. And tomorrow we will start such kind of a program in Poland. Second direction are healthcare providers. So we need to reimburse medical procedures devoted to diabetic food, of course, confirmed by EBM. And third direction is health professionals. So it is for us. We have to build a training system. We have to update our trainings, and we have to share competences. And now about competences. There are at least two groups of questions. One, there's a group questions, the questions about competence. Who is competent to treat diabetic food if we have so many limb amputations? Second, what right do we have to demand competences if we do not promote them widely enough? Now, the questions about educations. How do we educate patients? And there were beautiful examples shown by Dr. Abbas, Viswanathan, and Linda. How do you educate? But we have to look into our countries, into our regions. How do we educate primary care physicians? Are they enough educated? And third, how do we educate diabetes doctors and diabetes nurses in the prevention and treatment of diabetic food? I would like to show you the scheme of organization of care in diabetic food. Of course, every country has to prepare it on their own modalities, on their own mode. So how to realize and how to bring to life the system for prevention and education, the system for the treatment on the basic competences, and the treatment for when we have specialistic care for patients, for doctors and nurses with specialistic competences. And I would like to show you the scheme prepared according to International Working Group on Diabetic Food, who showed that we need at least 2 weeks from primary care to diabetes clinic on a minimal model, at only 1 month when there is insufficient care of the patient, into intermediate model. So everything is time. And coming into the end, I would like to show you the 5I concept. When the patient is in the middle and we are in the middle, we need technology, we need everything on time, we need flow of information, which has to be interactive, we need information, so we have to need sufficient knowledge, We have to integrate the influence between patient and GP. And of course, everything has to be individualized and we need database. And this 5 I concept is, I think, the ideal model, and each country has to prepare it on its own properties, modalities, and possibilities. Never mind, we have to share this knowledge. We have to do everything to decrease the number of patients with diabetic foot. And I'm showing now you the conference we are starting tomorrow, which is dedicated to primary doctors and so-called coordinated care. And thank you very much once more for Dr. Abbas, Hari Krishna, Linda, Mariam, Roberto, that we are together and we could change the life of our patients thanks to the guidelines, which we are showing now, thanks to the conferences, thanks to the workshop, and thank you for the cooperation between different associations. So we have to go hand by hand together, diabetic foot societies, diabetic societies, vascular surgery societies, orthopedic societies, nursing societies. I hope that during this conference, you could share the information about our declaration, and we'll be informing you in the near future about the assumptions of this declaration, and we'll try to implement the assumptions all over the world, and we'll try to decrease the number of amputations in each country all over the world. Thank you very much.